So our first panelist is our young dynamic bariatric surgeon, from Tamil Nadu, Dr. Christopher S.K., who is a consultant bariatric GI and minimal invasive surgeon and is founder CEO of Barios Center in various regions of Tamil Nadu. And he had been a national speaker to many conferences so far. Our second panelist is Dr. Jaydeep Pale, who probably has not yet joined. He's traveling and will be joining us shortly. He's well-known national faculty in hernia and bariatric surgeries and practicing from last 22 years in Mumbai. He's attached to various hospitals in Mumbai, including Leelavati, Jaslok, Safi, and Rich Candy Hospital. He has been awarded as Surgeon of Excellence for Bariatric and Metabolic Surgeons many times. Our third panelist is Dr. Vikram Lotwala. He is Director and Chief Bariatric Surgeon in Wings Hospital, Surat, and he is a visiting consultant to various hospitals. He has been faculty to numerous workshops and conferences since 2014. Now I like to invite our first speaker, who is well known to us, Dr. Sarfaraz Beg. He is specialist in bariatric and hernia and colorectal surgeries and working as a director of digestive surgery clinic in Kolkata. He is leading hernia segment of TUGS Society and distinguished representative of TUGS Society from India. He also sharing executive board member role with me in JMAS, the Journal of Minimal Access Surgery, and he is leading Hernia Society of India as well. He has authored many books on metabolic surgery and obesity. And there are a lot of many achievements which is difficult to elaborate here. He's presenting his recorded presentation today and will be available with us in question and answer session. And today his presentation is on recent guidelines in bariatric surgery. So let's start with his presentation. Parth, you can play that.
Hi, this is Dr. Sarfaraz Beg, and
Is the video audible?
I
Is the
bring
video audible?
greetings from Digestive Surgery Clinic based out in
Yes,
Calcutta.
it is audio. Yes.
Okay.
Thank TUGS and Dr. Vikas for giving me this opportunity to talk on a very important topic called the recent guidelines in bariatric surgery. So, the first guidelines on bariatric surgery was in 1992, and the NIH guidelines is something that we all followed for so many years. But there was a realization which was growing amongst the bariatric surgeons that with the addition of enormous literature, there has to be an update of these guidelines. And the most important guideline that came up was in 2022 when the ASMBS and IFSO combined published a guidelines with names of some of the most eminent bariatric surgeons across the world. So what were the key points? And I'm going to just take you through in the following slides some key points. The first key point was that conventionally with the NIH guideline, we used to believe that the bariatric surgery is recommended for patients with BMI more than 40, and if we had to operate somebody with BMI 35 to 40, then we had to defend or justify it by showing that there was at least one comorbidity. In this guideline, it was stated that irrespective of whether there was any comorbidity of whichever severity, one is absolutely okay to offer bariatric surgery for a patient with a BMI of 35. Now, this is a major advancement and comes because of the literature published on the topic where it's shown that patients with BMI less than 40 are doing better than patients who have been managed on diet, activity, and medical measures. The second statement, which is very important and reflects that there is a growing role of metabolic and bariatric surgery in patients with diabetes mellitus, is that it is now being recommended in patients with diabetes and BMI more than 30. So this is an important change and comes again from a lot of literature, a lot of case series as well as RCTs which have demonstrated head to head that the control of glucose levels are better with bariatric and metabolic surgery. Also, the complications, the vascular complications, the they are much better with the metabolic and bariatric surgery. So that's another important point. This comes as, again, as an extension of what we've been mentioning, even with class 1 obesity. Nowadays, metabolic and bariatric surgery should be considered. And this is for those candidates who have not been able to achieve any durable weight loss with non-surgical methods. It reflects that we acknowledge the increasing failure rate of medical measures in controlling obesity. It also reflects a perception based on publications that there are many individuals who may or may not have metabolic syndrome, which is overt, but in a subclinical level, and these patients also can benefit from the surgery. Now, it is now accepted worldwide that the BMI does not reflect the exact adiposity or the disease burden of a population. For example, Asians have a higher incidence of metabolic syndrome at a lower BMI because of our increased visceral adiposity. Therefore, the cutoff of BMI for defining obesity in an Asian population is now 25 instead of 30. Also, it is assumed that there is a higher need to do bariatric surgery at a lower BMI, and in this guideline, a BMI of 27.5 has been proposed to offer bariatric and metabolic surgery for the Asian population. As far as age is concerned, age per se and in itself is not an indication of or a contraindication to doing metabolic and bariatric surgery. Rather, frailty is something that is becoming more and more important, and it is measured by something called a frailty index. And if the patient has frailty or comorbidities which exclude them for having general anesthesia, these are the patients that do not get eligible for metabolic and bariatric surgery. But age alone is not nowadays considered as a contraindication. As far as children and adolescents are concerned, again, severe obesity, which can be measured in terms of BMI more than 120% of the 95th percentile, with a major comorbidity like diabetes or inability to walk, or a BMI more than 140% without any comorbidity, is what is considered as an eligibility criteria for doing a metabolic and bariatric surgery in children and adolescents. Literature has supported this view, and also to a smaller extent it supports the view also that even if the bone age or bone maturity is not attained, in situations which has to be tailored case to case, it is acceptable to do a bariatric and metabolic surgery even if the skeletal maturity is in question. There are certain concomitant surgeries which are benefited if a prior bariatric surgery is done. And these are typically the joint arthroplasties, the abdominal wall hernia repair, especially the larger ones, and prior to organ transplants such as the kidney, liver, and heart. In these patients, metabolic and bariatric surgery has been shown in the sparse literature that is available that the patients who are otherwise ineligible become eligible for these particular surgeries. It definitely improves the outcome as well. Now, the NIH in 1992 had stressed upon the multidisciplinary team, and these have been reinforced in almost every guideline that came thereafter. And even in this guideline published in 2022, it says that the team is important. It should come into play prior to the surgery, because it helps in education, in identifying difficult patients, modifying the risk factors, improving the perioperative complications, and also long-term outcomes. One of them, apart from the nutritionists, are the obesity physicians and psychologists. And this is statement, which is basically a very simple statement saying that severe obesity is a chronic disease, requires long-term management, indicates that we are now realizing that just like medical measures do not do well for severe obesity, similarly, bariatric surgery, when performed for class 3 obesity and higher advanced diseases, the recurrence rate would also be higher, and it should not be considered as a failure, but rather appreciation of the fact that obesity is indeed a chronic disease, should be staged like cancer, and just like an advanced cancer stage responds less satisfactory, so does obesity. So the revisional surgery is now no longer seen as something that suggests a failure of primary surgery, but rather looking at it as a continued treatment for a chronic condition such as obesity. Now, I will move on to the other guideline, which was published in 2019 and 2020 by the ASMBS as well as the AACE and the Obesity Society. And this was also an important guideline, primarily reinforcing whatever I've said in these 22 guidelines. But there are few slides that I wanted to add, which comes from this paper. First is that there is now a new term for obesity. It's called adiposity-based chronic disease, or ABCD. And this is an upcoming term which may replace obesity, since it conveys the meaning that more adiposity implies more chronic diseases. It helps the patient and the doctors appreciate that obesity is a disease, also makes them appreciate it's a long-term problem requiring long-term solutions. There is also another term called dysglycemia-based chronic disease, which suggests that insulin resistance is something which is an inciting factor, which occurs simultaneously in this disease. And when these two merge, then there is the beginning of a metabolic syndrome. So these terminologies help us in understand obesity better. As I mentioned earlier, obesity is now more assumed like a cancer, and it is better defined through staging system. And this is one of the efforts by Sharma and Kushner, which is called the Edmonton Obesity Staging System, which takes care not only of the BMI, but talks about the complications such as medical, mental, and behavioral. And when it accounts for all these three, it helps to grade the patient into stage 0, 1, 2, 3, and 4. So the first implication of this is some patients with lower BMI can be on a higher stage, depending on how much the obesity or adiposity affects the quality of life and the disease burden of the patient. And two, it also tells us the importance of recommendation for the surgery in higher stages. Third, it also helps us in understanding the prognosis as well as the treatment outcome in terms of downstaging and upstaging of the disease with time. There are anti-obesity drugs, and this is beyond the purview of this talk, but these are coming up as adjuncts, realizing that obesity is a chronic disease and everything has to come together, and all tools in the toolbox have to be utilized to optimize the outcome of obesity treatment. Endoscopic bariatrics, which has been in the horizon for quite some time, is making some progress, and there's certain balloons which are FDA approved, and endoscopic sleeve gastroplasty is also gaining popularity. We need to watch this horizon more carefully and see how much they contribute to obesity treatment, to the surgery, as well as in the form of revisions. Finally, this is what I'm going to leave you with. There is now an understanding, and this comes from the measure taken in the US, where the American Board of Obesity Medicine now has a certification for physicians who want to improve and specialize in the knowledge of obesity medicine, and therefore the outcomes of obesity care can be improved. And this is something that we have also incorporated in India, where we have begun our certification in integrated care of obesity, the SECO, and this course is certified by RC and endorsed by IFSO. And therefore, this is a huge development because it also is an indirect recognition of the fact that obesity management will need a multidisciplinary team, and the physician who expertise is in obesity has to be on board. With that, I thank you all for a patient hearing. I'll be happy to take questions, and I thank TUGS once again and Vikajan once again for this opportunity.
Sir, are you muted?
Thanks to Dr. Sarfraz, who has given a nice recorded presentation. It was really nice to hear such a clean voice with the recorded presentation. We will be joining in few minutes for any question answer session.
Yeah, I'm already here. I'm
Okay,
already
okay.
here.
Oh, that's great.
Hi.
So, we'll be discussing the question answers in after finishing all three talks, sir.
Oh, I'm around. Thank you very much.
So now we welcome our second speaker, Professor Dr. Raj Palaniappan, sir, who is Director and Lead Geriatric Surgeon in Apollo Hospital, Chennai, who did his master's in lap surgery in UK, and he is the first skilled bariatric surgeon in country. Now today we have requested him for a non-surgical topic, and we know he can speak well on anything related to the obesity, and he is the best one to deliver on it. Today he is going to speak on anti-obesity drugs. Do they really help? Welcome to Raj Palaniappan, sir.
Hello, everyone. Hope I'm audible.
Yes, yes, you're audible.
Yes. Okay. So, without further delay, let me get to the topic. Yes, I am given a very interesting topic of anti-obesity drugs, which is gaining much more popularity of late, especially with inadequate weight loss and weight residuism as a major concern in the last maybe 4 or 5 years. So, what exactly is the anti-obesity drug doing in bariatric and metabolic surgery? Disclaimer-wise, still not approved. They are in a clinical trial, so you have to be very careful about using them. But I'm giving you the and some of the products which are not supposed to be used for weight loss and for diabetes have been used for weight loss. Two kind of guidelines put in, and of course it's commercial and there's no conflict of interest. So going to the background, this image will give a clear idea about what is right now in weight loss management in the world. A lifestyle modification or intervention will help you in only 3 to 5% of weight loss. Very low calorie diet gives you 6 to 10% of weight loss, and any integrated balloon therapy will give around 4 to 6%. Pharmacotherapy giving 3 to 10%, gastric band 7 to 23%, sleep 9 to 38%, and gastric bypass 24 to 38% of total weight loss. When you talk about this kind of a thing, so there is a huge difference between surgical and surgical weight loss when it comes to excess weight loss. So the treatment gap is what we have to fill here. So an achievable weight loss by diet exercise is up to 5%, and achievable weight loss by bariatric surgery is up to 75% of excess weight loss. So there's a huge treatment gap between that 5-6% to 20%, 25%, that is where the obesity medications come into the picture, especially of late with a lot of new drug that are introduced. So the objective talk about the feasibility of anti-obesity medicine as an in the perioperative period, an adjunct after weight failure or a recidivism, or and then the recently advanced drugs as a clinical trials. So treatment strategy, we all know that there are 5 basic modes of treatment strategy of weight loss, obesity. Self-directed lifestyle changes by means of education and counseling. Professionally directed lifestyle changes by means of a bariatric physician, as Dr. Sarfraz said, or bariatric surgeon or other physician, pharmacotherapy, then weight loss surgery, and then if possible, combining everything possible together. So having all those in mind, let us have a basic idea about what are the anti-obesity medicines that are available in the market. For Indian population, we have only 4 or 5 medicines available in our armamentarium. One is Orlistat, whose action is energy wastage. We have topiramate, which is appetite suppressant. We have liraglutide, appetite suppressant again. We have a new drug called hardenine, which is a naturally occurring phenylethylamine alkaloid, which is a precursor to phentermine, because phentermine in India can be used enhancer, and semaglutide, the new block, which is the appetite regulator. So act on the brain, to the stomach, as well as on the endocrine organs and the pancreas, pace and things. So we have to work on various drugs depending upon is our issue. But as of now, the indication for use of anti-obesity medicine is more than 30 BMI without comorbidities, more than 27 BMI with comorbidities. So small gist about surgical physiology and how this anti-obesity drug has evolved. Surgical physiology, when they started understanding the base, they found PYY and the bile acids make a huge difference in the way weight loss. So it is heavily increased in sleeve as well as a bypass, especially GLP-1 and PYY. So bile acids also play a major role, even though CCK also plays a role, insulin also plays a role. GLP-1, PYY, and bile acids plays a major role in that. One has multiple mechanisms. It decreases the fasting insulin, increases the incretin effect, and decreases the hepatic glucose production. So by these means, this increasing the exogenous GLP-1 signaling considered the primary pathway leading to all other post-operative weight improvement by means of glucose. So that way, one is found to be the most effective way to lose weight. Coming back to an adjunct period, or the behind it, guideline wise, it has been told in super obese where pre-surgical weight loss is mandatory to reduce the intra-abdominal volume and achieve operability. Then for individuals who find it difficult to achieve weight loss with diet and exercise, add them on the medicines as well. As such, the use of weight loss medications may be considered as a treatment option as well. With that in mind, we go into some few interesting studies about AOM studies, especially Hutchinson et al., who has combined, pooled 8 of the studies and come out as a conclusion. So preoperative weight loss, he concluded saying that when there is a preoperative weight loss using anti-obesity medicine, there is a shorter length of hospital stay, which is significant. So if the patient has lost more than 8% of their weight, excess weight preoperatively, there is significance in the length of the hospital stay. That's a huge advantage what you're going to get post-operatively to patient to go home early. So this again gives a good idea about why not anti-obesity medicine. Then the same study in the Cassie et al. In a similar study of pooled of et al. Showed fewer post-operative complications, even though not very significant. Post-op complications will be around 18.5% against if you don't use anti-obesity medicine, just about 21.5%. So depending upon the weight loss because of AOM medicines, the post-op complications have come down as well. And again in Hutchison et al., there is a greater excess weight loss as well if you preoperatively use the anti-obesity medicines. So the patient has lost more than 8% of preoperative excess weight loss with the use of medicines. They have much more enhanced weight loss post-operative as well, which holds about some 10%, 8 to 10% more excess weight loss. So these kind of studies have really given us an idea about how to go about using adjuvant chemotherapy using AOM. So then came the liraglutide studies. The previous studies were phentermine and topiramate and other studies. So when the liraglutide came in, so they did a liraglutide study in the preoperative weight loss comparing over gastric balloon. Interestingly, liraglutide give a significantly good weight loss compared to even intragastric balloon. Surgeons stopped using intragastric balloon as a preoperative weight loss tool and started using anti-obesity medicine. So a 26 kg weight loss against a 21 kg weight loss by balloon, and even the number of days, in 3 weeks you get the good weight loss compared to 4 weeks when it comes to intragastric balloon. So you tend to operate these patients pretty early if you use a AOM and a good weight loss, significant weight loss using a AOM than using a intragastric balloon. So this study is really a good landmark study which proves that anti-obesity medicine is a very good tool to make the patient much more recovery being less after using AOM as a preoperative tool. Again, liraglutide study is compared to very low calorie diet study. Again, significant. So here again, the patient have a very good weight loss of about some 6 to 7 kilos against 4 kilo weight loss when compared to VLCD in 2 weeks time. So that's 2 or 3 kilos extra weight loss gives much more benefit and significance in the weight loss, and thus helping them to have a much lesser post-operative complications as well as early recovery. So that's a pretty good study as well, comparing liraglutide in the preoperative period. When it comes to post-operative rational, we all know that guideline-wise, enhancement of suboptimal or post-operative weight loss and rescue of post-operative weight regain, we use anti-obesity medicine. Again, allows a personalized approach to account for patient variability in response to the medications, and as a standard sequential trial and error basis also can be approached at anti-obesity medicines. So there are good studies about post-operative anti-obesity medicine as well. This Gravitas study, a very interesting study using liraglutide 1.8 milligram per day, though not approved for weight loss, they have been tried, and there has been a very significant post-operative weight loss when compared to placebo study right from 6 weeks to 26 weeks. So the significance starts from 6 weeks and until 26 weeks, there's a good significance, and the gap between the placebo study and the liraglutide study widens with time. So by end of 4 to 6 weeks, 6 months, difference of 6 to 8 kilos weight loss. The good amount of weight loss, about some 12-15% of total weight loss. That is a very high number. There are plenty of studies which has used. There are some 7-8 studies which compared placebo to liraglutide and combination of phentermine, topiramate. Everybody has said that there is an increased 19% excess weight loss against a 37% weight loss when there is use of AOM. So that's very, very classically, there is a huge difference between 12 to 15% increase in the excess weight loss or total weight loss when the patient is on anti-obesity medicines. Then the topiramate trial, which happened again with the 40 students by Koshish et al., has again set a very good significant difference between using topiramate as anti-obesity medicine adjunct post-operatively along with surgery. There is a huge difference, as significant as well. So coming to the therapy as such, stepped care is the recommended way to go about medical therapy followed by the surgical care, and particularly with a good lifestyle changes, and generally stopped at the time of surgery and restarted after surgery again. And again, perioperative weight loss primarily benefits in liver fat metabolization preoperatively and short-term calorie reduction of meal replacement and anti-obesity medications. Simultaneous initiation of combination therapy post-surgery gives you a very good weight loss, creates the problem of not which drug is used in these patients, but then preoperative is a good weight loss, can use the same drugs post-operatively. And of course, it's very difficult to have the post-operative, which medication helps bigger because of the synergy of procedure and together. However, we try to use successful medicine. That is why we try to recommend at least a month before surgery. Couple of weeks later, the medicine is not working, you can change it to new medicine and then see how it works and then use the same medicine post-operatively as well. Now coming to second, AOM as an adjunct after weight loss, weight failure or recidivism. When it comes to weight regain or inadequate weight loss, there are patient-specific factors and surgeon-specific factors that has been postulated. Patient-specific, most commonly in the urge and emotional eating, reduction in physical activity, mental health with a lot of medications, nutrition complaints not being followed up properly, poor follow-up, hormonal imbalance, and preoperative variables as well. Surgery-related, a poor surgery, a dilated gastrostroma, a gas sleeve, or left behind fundus, a gastric fistula, a residual volume is left behind, and retained fundus are all the reasons. Again, patient factor forms more than 60% of the cases. So that way, these 60% of the cases can be managed if the AOM is given as an adjunct therapy. So there is a studies which show some very interesting results of using liraglutide in inadequate weight loss. Post-operatively, inadequate weight loss, 48 patients have been chosen who are in a sleeve or a bypass or a band and added liraglutide to them. By end of 7th month, they have a very significant weight loss, about 12 to 15 kilos added weight loss after inadequate weight loss. That is a huge bonus adding anti-obesity medicine than by considering a revision surgery for these kind of a patients, where as of 15 kilos extra is a very good number at the end of 7 months after starting the anti-obesity medicine. So liraglutide did help in the REGALA study. And when it comes to weight regain, so previous study was about inadequate weight loss. Now in weight regain, if there's a recidivism, in long term, as many as 10 to 20% of patients regain all the weight. So adding this anti-obesity medicine reduces that comprehensively. So there's a RISE study which has beautifully said that with a weight regain back at the end of 1.5 years, you start liraglutide. So the study showed patient with around an average of 130 kilos. This up 28 patients has been taken out, and the liraglutide 3 milligram therapy started. The average weight of 130 kilos at start, and then nadir is reached where they have 95 kilos, but they go back and more. They became 140 kilos, and these patients started liraglutide of total is easily achieved weight regain patients. So inadequate weight loss as well as weight regain, it helps in a big way. So we did our own study called Hardinin and Tomate study called Hot Top study we started. So we have 2 types of treatment, Hardinin 30 milligram and topiramate 25 milligram to start with, and increase it to Hardinin 60 milligram and topiramate 50 milligram. So we did a 5-year study. So we have 72 patients who tried on this for inadequate weight loss or weight regain with a mean baseline weight of 112.4. And see, at 12 months, these people are able to achieve 95 kilos, which is an excess weight loss of 20%. That's a very good weight loss, which can really avoid having surgery, might fail us. And Wayne Young et al. Had a study presented in Sages where inadequate weight loss, 71% chances of inadequate weight loss has better results than weight regain when you add medicine to it. So inadequate weight loss has better results than weight regain patients. So that is the reason why start anti-obesity medicine pretty early when there is inadequate weight loss and don't wait for weight regain to happen. And of course, in a bypass procedures, it helps much better, 75%, than in a sleeve procedure. And early pharmacotherapy responds better and better control of glycemia and dyslipidemia as well in this study. So recently launched AOM and their clinical trials are also very interesting, especially with the introduction of semaglutide, the new kid on the block, the blue-eyed boy of weight loss as of now, 2.4 injection. And in this, in Wilding et al., beautifully the use of semaglutide and placebo with a very significant difference of 16.9% change in the baseline weight against 2.4% baseline weight with the placebo. That's a huge difference. So that again proves to be very, very good in case of use of semaglutide, a GLP-1 analog. So exactly the GLP analog, what we spoke about, the main mechanism in surgical principles. Since the GLP-1 analogs come into the market, this has been found to be of much help across the board, whether you want a pre-operative weight loss, post-operative weight loss, or inadequate weight loss, or weight regain, can be used in any format to be used as a tool for excess weight loss management. SEMA-G study is our own study. We use semaglutide, 13 patients. We use semaglutide, and a short-term weight loss of 8 months were tried. And if surgical group, a weight loss about 134 has come down to 119.84 in 8 months, which is about around 20 kilos, 18, 19 kilos. Whereas if you use adjunct chemotherapy, with the semaglutide, it goes down to 108. So we have another 11 kilos weight loss excess to these patients after inadequate weight loss. So if the patient after inadequate weight loss or weight regain, if you add semaglutide to it, so I have a 9 kg excess weight loss, total weight loss in these patients in my series. And again, so that's a very, very good indicator that we can use AOM as early as possible to make sure that we have the better results. So when it comes to inadequate weight loss and weight regain, the therapeutic approach is re-optimize the patient lifestyle, physical activity, healthy diet, sleep, biometrics and stress, all those things. Consider revision to a different operation. If when then we can always talk about revision, but add form as early as possible as a complementary mechanism can provide additional benefits and can avoid revision operations as well. So to summarize all these things, we had under the leadership of Dr. Raman Goel, myself and Sarfaraz also were part of it. We had a consensus meeting for anti-obesity medicine and bariatric surgery. So we come with algorithm. So what happens in AOM therapy, pre-operative AOM therapy, start these patients. If the weight loss is less than 5% in 1 month, stop the drug therapy or start new drug. The moment you start new drug, we can always repeat the assessment process and see between 1 and 3 months, minimum of 1 month is needed to have a good results of the therapist to be seen. Because again, this will be helpful for us to understand what medicine helps us, and the same drug can be used post-operatively without knowing whether it will help or not. Post-operatively, if continue with the therapy, if the weight loss is more than 10% in 3 months' time, continue the therapy. And if you want, you can add new drug as well. If the weight loss is less than 3 months, that means going on. So stop the drug therapy or start a new drug, whatever if you wanted, or you can look into other means of trying to reduce this, to improve the weight loss. For inadequate weight loss and weight regain, again, if the patient is not able to lose weight less than 10%, more than 10% in 3 months' time, or if the patient has gained more than 30% of weight after the weight loss, start drug therapy. And in this case, there could be a possibility of indefinite therapy of AOM as well. So this gives a very good picture about how to go about adding AOM to bariatric surgery. And to conclude, AOM is very effective adjunct to surgical weight loss. Given preoperatively, improves the postoperative outcome and compliance of the patient. AOM helps in long-term weight maintenance and reduces weight regain as well. An effective alternative to surgery in failure or weight regain. And very few RCTs in the preoperative period available. So we need more studies to understand how to go about the AOM. So to answer the question, do they really help? Yes, they do really help. So I would like to conclude saying that it's a world has come to a stage where adjuvant chemotherapy is the way to go. Anti-obesity medicines have to be added at some point of time. Better to start early to get a better results, because obesity is a multifactorial issue and it can't be tackled by having one control or two controls. So hit it as much as possible so that you get the best results. Thank you.
Thank you, Dr. Raj. It was really exhaustive discussion on the medical management and bariatric surgery. And in addition to all your first, I could see in your CV that the India's first robotic revision surgery, first robotic gastric bypass, first robotic sleeve gastrectomy. Probably you are going to be a first medicinal surgeon in bariatric surgery as well. Thank you, sir.
Thank you so
So
much.
now, yeah. So now I will invite our own team member, Dr. Digvijay Singh Bedi. He's the third speaker and co-organizers for this meeting with us. He is director in Hope Obesity and Super Specialty Hospital in Ahmedabad, and he is going to present on metabolic surgery, the expanded horizons of bariatric surgery today. Dr. Bedi, sir.
Right. So I hope I'm audible. Let me start my topic.
Yes. Yes.
We've all been talking of how complex the obesity is. But the other aspect to it is that every person perceives obesity in a different way. So as Dr. Raj right said, there can't be one approach or one thing which can, solve the complete problem of obesity. It is pretty complex for that. So we are here to basically discuss what is metabolic disease, how the diabetes surgery guidelines were actually laid down, the certain studies which have shown the impact of surgery on metabolic disease, and how to approach a patient. So these would be my headings under which we'll quickly discuss everything. So we all know what metabolic syndrome is without going much into detail of it, but the major chunk of this cake is taken by insulin resistance, type 2 diabetes, hypertension, and heart disease. That's why we call it as cardiometabolic disease. And in short, if we want to just know the mechanisms, so the central obesity leading to adipose dysfunction and microvascular dysfunctions, leading to low-grade inflammation and insulin resistance, causing all the issues of high blood pressure, high triglycerides, high glucose levels, leading to metabolic syndrome. So this, in short, is how a metabolic syndrome develops. We all know diabetic complications of macro and microvascular ones. So let's embark on this thing. So till 1925, there were several reports which showed that the diabetes resolution was there after a stomach surgery. But there was no bariatric surgery at that point of time, and it was only 1955 when a weight loss surgery or bariatric surgery was introduced. So between 1970 to 1995, several reports started coming in which showed remission of diabetes after bariatric surgery. And in 2004, there were certain animal experimentations also showed positively changes in the glucose metabolism. And in 2006 and 7, studies in humans also started. So in 2007, the first diabetes surgical summit was organized. And from there onwards, between 2008 to 15, a plethora of clinical trials demonstrated effects of surgical treatment of diabetes. And in 2015, second diabetes surgery summit was done. And in 2016, the guidelines for surgical treatment for diabetes was given. So that's a long road that the metabolic surgery has taken. So this was the first DSS summit, and as you can clearly see, Dr. David Cummings, Lee Kaplan, and Dr. Rubino, who were the stalwarts in this thing, part of this first summit. The very important part of this summit was the clinical diversity. So you can see about 7 major specialties coming into it, with about 14 countries joining into in this expert committee to lay down the guidelines. And finally, surgery became a standard treatment option for type 2 diabetes. And in 2016, a joint statement by international diabetes organizations were given, where very clear-cut guidelines as to how and when metabolic surgeries can be taken on was given. So, if you look at from 1920 to 2016, so conceptually, introduction of metabolic surgery in the managing algorithm of diabetes is the most radical change which has come in the history of disease since the discovery of insulin. So after 1921, when insulin was discovered, 2016, the metabolic surgery was the most impactful thing which came in this thing. These guidelines, which have been given particularly for the general practitioner, endocrinologist, and diabetes specialist all together, contains about 32 statements, which gives statements about general framework, definition of success of treatment, patient selection criteria. So this goes beyond the scope of this thing, but it is a very comprehensive guidelines which need to be followed, which standardizes the treatment options that we give to the patient. So, when you talk of diabetes guidelines and bariatric surgery guidelines, so the bariatric surgery guidelines addresses a very small subset of surgeons and physicians that we're talking, while diabetes guidelines addresses to a very large subset of people, including GPs and diabetes care providers as well. That's why bariatric surgical guidelines is for very, very small subset of patients who actually seek obesity treatment. But DSS guidelines is for all the patients who are seeking treatment for diabetes. So there's a huge difference between the two things. Though they both see a different entity, bariatric surgery and diabetes surgery, at some point of time, this is gradually merging, or rather I would say it's already merged, and diabetes surgery has become a part of bariatric surgery. So coming to the indications and when and how it has to be done. So this algorithm is, if we can quickly go through this, the patients who have type 2 diabetes can be divided between non-obese, that are the ones who are less than 30 BMI, in which, of course, non-surgical treatment takes the precedence. For the obese patients, particularly of class 1, optimal lifestyle and medical management is to be started with, and the ones who have good glycemic control are put on non-surgical management, just as non-obese patients, while the people who have poor glycemic control in class 1 obesity and the ones who are in class 2 obesity, that is between 35 to 40 BMI, who've been on optimal lifestyle and medical management, though are having an adequate glycemic control, are opted or given an option of metabolic surgery. So these are the patients in whom metabolic surgery can be considered. Finally, the class 2 obese with poor glycemic control and class 3 obese with diabetes, of course, metabolic surgery has to be recommended as early as possible. So this is the subset of people that we're talking of in whom consideration or recommendation of metabolic surgery can be done. Coming to the studies which have made a positive impact on this thing, Stampede trial, as you all know, has been a very, very important study. If you look at this slide in which there is comparison of medical and surgical management in patients who are less than and more than 35 BMI, type 1A evidence clearly shows surgical superiority in patients over and less than BMI 35. But in both these subset of patients, the outcome is similar and superior in case of surgery. Moreover, HPA with surgery and even with fewer diabetes medications as compared to non-surgical patients. So this trial was really eye-opening for many people. Of course, nice guidelines have been laid. I'm not going too much into detail of it, but this is a field-trial study in which it's very important that there are certain predicting factors of diabetes control that have been considered in this study, of all the age, pre of BMI, post of BMI, the duration of disease and duration of insulin usage. These are the two major factors which have decide the outcome after the metabolic surgery also. So a slide clearly shows that if you see that the patients who are having diabetes less than 2 years and the patients who are having diabetes more than 4 years, if you see the comparison at the end of 2 years, the patients who have recent onset diabetes, almost 100% remission is seen. As you move on to almost 15 years, the remission is still around 50% in patients who have diabetes for less than 1 year. While the patients who had diabetes for more than 4 years, the remission rate goes down to around 10% in these patients. So this subset of people are the ones, so the longer is the duration of diabetes, the remission rate gradually reduces. Another very good study on this is Mindron study, where bariatric surgery versus medical therapy was considered. And as you can see, the clinical benefits of surgery in terms of remission. So there is a durable remission of hyperglycemia in about 50% of surgically treated patients over a period of 5 years. If you compare Roux-en-Y gastric bypass, again, you will see that most of the patients are in either remission or have substantially improved glycemic control even at the end of 5 years. Now, another very important thing is that most of these patients either do not need any medication or are on a very, very small dosages of oral medication to maintain a glycemic control even after 5 years in the patients who undergone surgery. So this clearly shows the superiority of surgery. Again, a very good slide, and I really love this slide, is that at the start of the clinical trial, if you see the percentage of patients who are using insulin are almost the same. At the end of 2 years, the patients who undergone surgery, there is absolutely almost zero usage of insulin. At the end of 5 years, it's a very minimal usage of insulin in patients who undergone surgery, while the patients who have not undergone surgery are still using insulin. But very important thing is that in these patients, the usage of insulin has actually increased as compared to start of the clinical trial. So, there's a continuous up graph for these patients. The quality of life after the surgery, again, has been found to be very good. And if you look at the metabolic milieu, not only the weight loss, but also LDL cholesterol, HbA1c, and the blood pressures are all on a lower side in patients who undergone surgery, metabolic surgery, as compared to just lifestyle and medical management. So surgery plays an important part in every aspect of the metabolic disease. So coming to the choice of procedures, so these are the procedures that have been tested against standard medical treatments in RCT so far. So there are many more type of surgeries, but officially speaking, you can say gastric bypass, sleeve, BPDDS, and gastric banding have been, studied as an RCTs. And I can very shortly, already this part has been touched by both Dr. Sarfraz and Dr. Raj. So if you look at the mechanisms as to how these surgeries work, so there used to be a gut hormone theory of foregut and hindgut theory. I won't go into detail of it, but there is another theory of gut microbiota, which again held an important part for quite some time. But the one theory which is now accepted worldwide is the fat mass set point theory. Shows that there are, so over a period of years of over a period of time, all abnormally dietary constituents, sleep deprivation, stress, so all these factors shift the body fat mass up, and the surgery shifts this set point down. So it's a balance of how it is done. So it can be diet, it can be exercise, it can be a combination of diet, exercise, and drugs, which all come under this segment. So, why surgery actually has a longer and better remission? It is only because it pushes down to such far level that it's difficult for the body to bring it back to the initial set point. And that's why you see longer duration remissions of weight loss in surgery. Finally, International Diabetes Federation has come up with all these definitions. So there is not only optimization of metabolic state, but they've also, improvement in metabolic state have also been defined. So there are clear-cut guidelines, and we all know how to move about it. If you look at the national healthcare budget, so it doesn't apply much to India, but it's gradually going to be. Mediclaims have started up for metabolic procedures. So if you see that obesity budget is very small as compared to the bariatric surgical budget, this was what was the scenario. But when you immediately shift your focus to diabetes budget, it is much, much more than the amount the nation has to spend on bariatric surgery. So, this factor has been a key thing in places where the national healthcare budgets are decided, like NHS, where this factor was taken into consideration. And of course, the media has played a major role in highlighting this positively as well as negatively. So, it's high time that we start to think a little differently about the surgery, and no longer a bariatric surgeon has to like this in front of their colleagues and diabetologists, because there is a paradigm shift on how we approach the surgery. So this slide has come up earlier also, starting from, so surgery is not the first line of treatment for all the diabetes. So starting from self-directed lifestyle change to professionally directed lifestyle change, head-on medications, and then finally weight loss surgery comes into the existence. So just as Dr. Raj stressed it, so we need to have a multidisciplinary approach. It can't be one thing doing all, and surgery is not, we are not gods. So basically, we need to take care that we apply the medication part, the lifestyle change also, to address a complex thing as obesity. And very important thing is that though they all may look the same, but you really have to give a very personalized, you have to give a very specific treatment for individual patients. So detailed assessment of the patient is very important. So in my conclusion, I would say that yes, it's a chronic disease, so it needs a chronic treatment, and surgery in combination with medication has better results. We all have heard this, and we need to win both the hearts and minds of all our colleagues. So that's all I have to say. Thank you very much for inviting me to give this topic. I'm open to all the questions. Thank you so much.
Thanks, Dr. Biddy, sir. You have written back to the surgical discussion. Thanks a lot. Now, I think we can start from the questions in chat box. There are not much questions in chat box today because all of our speaker has given such a exhaustive and such a great discussion that people are speechless actually. There is a question by Dr. Sanjay Sonar for Raj Palniappan sir. Sir, what are the complications of AOM usually?
So usually the problems will be with regards to nausea, vomiting, some cramps by use of these drugs, the present GLP-1 analogs. If at all using phentermine, topiramate, then there are some psychological effects as well. They cause some depression and sometimes anxiety and restlessness. So apart from this, there is not much of deficiency. But of course, every AOM will have nutrition deficiency in the long run as well. So any FDA approved drugs, they didn't have too much of post-operative post AOM complications much, except for these kind of a small combinations of complications which can be really managed with multi-drug therapy, reducing the dosage and stuff like that.
Anything you want to add, Christopher or Dr. Vikram?
Sir, I have also, Raj, sir, I have also used semaglutide for a few of my preoperative patients, and I found that there was a significant difference between what we have done before that and now after using a drug. So I feel whatever you have told in your slide, it is actually it's working good. So either the weight loss before preoperatively and also the along with the the very low calorie diet and the size of the liver and everything is actually better compared to what we have been doing before.
Totally, that's true.
Dr. Vikram, sir, do you want to add something else? You joined late. I know that you have missed the session. Yeah.
Yeah,
Okay.
I've learned. But I think that's good enough. I agree with what Dr. Raj said. I think there was some study done. I don't know if that has been discussed about giving pre-op also for weight loss. If that discussion has been done, where some centers have started giving with the protein powder and liquid diet for the liver size reduction. Some centers have started a trial giving semaglutide also for initial weight loss before the surgery. That is working well. That is what the information is.
Fine, fine.
Vikas, can I make a point here?
Yes, yes. Why not?
Okay. So, according to the recent guidelines 2022, the IFSO ASMBS that I referred to, in those guidelines, they looked at the literature on preoperative weight loss and its influence on the outcome of bariatric surgery. Although intuitively we would think that a preoperative weight loss would also translate into better outcomes, it did not show any benefit in most of the literature. And therefore, the guidelines have not placed that as a recommendation. That's number one. Number two, the anti-obesity medications such as the GLP agonists also work by the principle of gastroparesis. And recently, the American Anesthesiologists Associations have placed a diktat or recommended that these should not be used prior to surgery, but rather stopped prior to surgery so that in the post-operative period, you do not have nausea, gastroparesis, and bloating. So these are 2 points that come from the guidelines, and I think it is important to place them here for the sake of audience.
That's good, sir. So, Dr. Sanjay has again asked, did you have to discontinue this drug due to the side effect?
So yes, we have discontinued 2 patients due to cramps. severe cramps causing a lot of discomfort. Otherwise, nausea, vomiting is not much of an issue in any of the other patients. And of course, these two patients, even with 3 milligram, they had side effects. So some people will have 14 side effects. So we'll bring down to 7 milligram and escape. So most of the time we escape. And then to add to Dr. Sarfraz said, yes, there has been a lot of negativity going around use of AOM, but all the weight loss of AOM failure was before semaglutide usage, when there were phentermine, topiramate were used, because side effects are more, the weight loss is not great. So with semaglutide clinical trial coming up, I think it will reopen the gates for using them as we. And you rightly said the issue of gastroparesis being a problem with the use of GLP-1. So that's why we always say that stop it 3 to 5 days before the surgery and start them again later after 3 to 5 days after surgery once the patient starts on semi-solid diet or so. That's how we recommend, and it's helping. But of course, we never had major issues, but recommendation wise, you should not use it during the surgical period.
Dr. Sarfraz, uh, one of our participants asked that is stopping the drug pre-op and starting it post-op. So what time is recommendation for both to stop and the restart?
So I won't be able to say exactly what the time duration, but it is definite that they stop it before the surgery, a week before. How soon can they start? Well, I'm not sure on that. I am sure that must be on the basis of the discretion and case to case basis. I think so. I'm not sure on that. But if I remember the guidelines correctly, there are no recommendation as to when it can start. But I'm presuming it will be on case to case basis.
So I think we have finished our questions from the chat box as well. I request if any of our panelists want to add or anything to discuss about speakers.
Yeah, and one more addition to that, starting and stopping and starting of AOM. All these studies were done on mostly orthopedic and other general surgical cases where the patient is on semaglutide, and these stomach are normal stomachs. So postoperative paralysis was a major issue. In a bag with a 25 cc to 50 to 80 cc pouch, and with 2 to 3 days of no diet or liquid diet, which is pretty less, there is not much of a clinically evident concept of having paralysis be a major issue. But we have to do some clinical trials and RCTs to really come with a final conclusion on that.
Dr. Christopher?
Yeah. So as Dr. Sarfaraz sir said, stopping the drug 1 week before is what we have been practicing actually. So after the surgery, till now, I have not started for any of my patients. So probably as I have to just check for my future patients and see the results how Dr. Raj has explained. So probably I have to do that.
So we have finished our chat box questions as well. And I request my colleague this part to conclude the session for today. Hello, Dr. Jaideep. Dr. Jaideep is there? Dr. Jaideep, sir? Dr. Jaideep, are you there? Okay. So, Parth?
So thank you for giving me the opportunity to thanks. Today, being a surgical group of TUGS, we have discussed about recent changes in the guidelines of obesity management and about the anti-obesity drugs. So this tells us about the direction in which the change is going and how Dr. Raj clearly elucidated how the importance of anti-obesity drugs is increasing. And all the panelists and speakers today gave us a wonderful insight into the management of obesity. I thank you all for your valuable time, and it was a very good discussion at the end. I would like to announce the next TUGS second edition of TUGS India Academics will be held on 8th of September, and the topic for the next session will be on liver anatomy and dissections. And this is the group link for joining the TUGS India group in case you have not joined. We have monthly sessions of TUGS India on the first Friday of every uh, on the second Friday of every month at this time. So see you all on in the next session. Thank you. All the participants who have attended today's session will receive a certificate on their email. Thank you all. Back to Dr. Vikas, sir.
Thank you, everyone. Thank you, Sarfraz sir, Dr. Palaniappan sir, Dr. Vikram, Dr. Dwivedi, Christopher. Thank you, everyone. It was really nice session for today. Thanks.
Thank you.
Thank you.
Thank you so much. Thank you.